I am delighted now to turn it over to Marcus Escobedo, who is a Senior Program Officer and Communications Director for the John A. Hartford Foundation. He will be moderating our final panel on caring for an aging population. Thank you, Marcus.
Thank you, Sarah. Really a pleasure to be here. Welcome our panelists. This is very exciting for me, getting to be with an esteemed group of experts in improving care of older adults. It's the mission of our foundation at the John A. Hartford Foundation. So let me start with introductions, and then we'll get right into the questions and have this, I think, a lively discussion today. So first we have Clare, who is Assistant Professor in the Department of Family Medicine at Michigan State University in their Geriatrics and Gerontology program. She has 40 years of experience as a gerontologist, and the majority of her research has been related to workforce development, particularly labor conditions, and training of direct care workers, which we'll talk a lot about today. We also have with us today Joanne Lynn, who is the director of the Center for Elder Care and Advanced Illness at the Altarum Institute. Joanne is one of the first hospice physicians in the United States. She's the author of more than 250 articles and several books on palliative end-of-life care, and she's been a medical officer for the Centers for Medicare and Medicaid Services. And then we have Tom Edes, who is Director of Geriatrics and Extended Care for Clinical Operations for the Department of Veterans Affairs. And Dr. Edes has national responsibility for operations and management of the VA's spectrum of services across all settings of care. And I do want to note that Tom has also been a past president of the American Academy of Home Care Physicians, and I think we'll be talking a little bit about that area today as well. So thank you all for being here, and let me start by going back in time a little bit. I'm gonna go all the way back to 2008. It was just a couple of years after I had started my work at the John A. Hartford Foundation, and a report came out called Retooling for an Aging America, Building the Healthcare Workforce. It was an exhaustive study examining and asking the question, is our workforce in healthcare prepared for the rapidly growing aging population? This is in the context of not only a doubling of the older adult population in a relatively short period of time, but with that coming, of course, higher rates of multiple chronic conditions, the rise of serious illnesses and conditions like Alzheimer's disease and dementia, the fact that 70% of us, if we reach the age 65, will at some point need assistance with daily activities, on average for 3 years. All of that really creates what the committee at that time felt was a really important need to examine the workforce and ask that question, are we prepared? So I'll quote Jack Rowe, the esteemed leader of the committee at the time, who responded to the Senate, no, we are woefully unprepared. Woefully unprepared was his remark. So I want to come now to today, and I want to pose a question to the panelists. Given what the Elder Care Workforce Alliance, who's a co-sponsor today, has been talking about in their work, that we are still woefully unprepared, I wanted to ask the panelists, how do you see the state of the workforce as it relates to the aging population today? I'll keep this pretty general and broad, and really specifically, where do you think we should be putting our energy, our attention, our action when it comes to creating the adequate workforce that we need? I'm going to start with Tom at the end, if that's okay, and work down.
I think woefully unprepared is a reasonable description right now. I think because we're facing still such a climb. And I'll be a little bit specific to VA. For example, in the 2 decades between 2000 and 2020, the American population over the age of 85, fastest growing sector, was expected to increase 72%, roughly 70% over 20 years. What happened in the VA? In the VA, the population of veterans over the age of 85 nearly tripled in half that time and doubled in 5 years between 2000 and 2005. So we've been anticipating this, recognizing that the curve is steeper for us, a much sharper magnitude. We've been working on this for decades, so we have some successes, right? And so one of the things I guess I'd like to bring into this is the need for opportunities for really robust interdisciplinary team training. And we have that in a few settings, right? Many geriatric programs do that, our geriatric clinics do that, our hospice agencies can create that setting if they're connected with training to do that. But in VA, which trains almost 2/3 of the healthcare workforce of all disciplines that practice in geriatrics, we have home-based primary care. Home-based primary care gets into the home, so it's focused on, nearly 40% of that top 5% of the population who accounts for 50% of healthcare costs. And in the VA's model, we have physician, nurse, social worker, dietitian, pharmacist, really proud of a mental health provider in every team. And if I didn't say rehabilitation therapist, that's a part of the team. So it's a very strong team, and it's a great site for interdisciplinary team training to really get that experience. That, to me, is where, to take care of this population, we really need people trained in every element. Did I say social work? I don't remember. But that's, I just want to, it's a very robust, encompassing team, and bringing people together to work together for complex care needs is something we need to be prepared for.
That's a great point and a theme that we've heard throughout today's session. Joanne, what's your take on where there's really opportunities for action or where you see biggest needs?
Well, how many people here want to grow old? Yeah, okay, everybody. How many want to have a couple of years of serious disability at the end? It's interesting how everybody wants to grow old, no one wants to age. And yet the average is now a couple of years. And where's that help going to come from? There are almost no geriatricians, the number is going down. The geriatric skills are not actually taught to most primary care doctors. Nobody wants to work with this population. It's really tough. I mean, it's the hardest work around. And yet we don't even pay a living wage to the direct care workers. We pay nothing to the family volunteers. Most other countries provide a stipend, provide respite, provide all manner of support. It's almost as if we set out to see how hard we could make it. And so what's the upshot when we double the number of people who are old and frail? I mean, when I first started working in elder care in 1978, there were whole states where half of, or more than half, of the people in nursing homes were tied down every day. There were whole facilities with half of the patients having pressure ulcers. We don't see that level of horrible care in general anymore. But those weren't awful people doing that. Those were people who didn't have the skills, didn't have the resources, didn't have the standards set. We could slide back to that in a flash. We could have people dying much more quickly because they simply don't get fed. In Detroit a couple of years ago, I was there, and the wait list for Meals on Wheels was 850 people. Most people died or went to a nursing home before they got fed. We are so blind to what it is we face, and yet everybody here wants to join this group. You know, I mean, it's the only minority group to which we all aspire. And yet we're doing nothing important about financing or training the workers that we need and generating the skills that we need. It's as if we somehow think magic is going to happen and it's all going to miss us. We're going to get to be 95 and die in the arms of our lover and, you know, fresh off the golf course. Not likely. Not likely. And, you know, to the extent we keep wiping out one disease after another and doing better at prevention, we make it more likely that we're going to have frailty as our course. Frailty is a uniquely difficult course. Person's sharp, mentally aware, and can't get out of a chair. We need to change we'll come back to this later, but I think we need to change the power relationships. We need to change how we value this part of life, and we need to change who has the say over it. It can't be the surgeon in the hospital who's never been on a home visit. You know, it can't be the legislator who thinks he's going to be rich enough to get out of it. We have to get the caregivers involved and really develop a political force.
Touching on some very important points, Joanne, that we'll dive into, I think, in more detail in a moment. Let me turn to Clare and give your perspective on where we are right now and where the biggest areas of opportunity might be.
Well, here, that was well said. And Robin Stone is not here, so I'm going to yell on her behalf because up until this moment, most of the discussion this morning has been about clinical care settings and licensed professionals, and the shortage in aging care. There are shortages across the board. We don't have enough geriatricians, nurse practitioners, social workers, but we really don't have enough direct care workers. The crisis is already here. It's not coming, it's here. There are home care agencies across this entire nation who are dying out there. They're desperate. They don't have the direct care workers who are the people that allow you to stay at home. So I think the end game for a lot of the clinicians and the specialists is high quality care, right? You want to give the best care possible, but I think you have actually a bigger goal than that. You want your patients and your clients to be able to have a high quality of life at home for as long as possible, as independently as possible. The only way they're going to do that is with direct care workers, paid direct care workers, and family caregivers. Family caregivers and direct care workers are the ones that are there day in, day out, doing the hands-on care that gives family members relief, but also provides the care that allows people to stay at home. Now, I, for many years, was a nursing home and home care social worker. Important job. All of these specialties are important jobs. But I would go into a home maybe once a month, set up services, help with the healthcare bills, do some counseling, things like that. But those direct care workers are the ones that are in there every single day, making it possible for people to stay at home. And yet we undervalue them, underpay them, give them no respect. I think on the positive, we're supposed to talk about solutions, I know. So on the positive side, I guess if you can frame it this way, we've seen this coming for decades. We've seen the aging of the population coming for decades, right? One of the things that hasn't changed is family caregivers still provide the majority of care at home. But because people are living longer, women are in the workforce, all kinds of reasons, they can't handle it all. We have the sandwich generation with people working, taking care of older adults, and taking care of younger kids. They're being stretched in all these different ways. They can't handle it anymore, so they turn to paid care. What kind of care do they hire? They hire direct care workers. 80% of paid in-home care is from direct care workers. 80%. And so I think that if we didn't have them, the home care would actually crumble. People would not be able to stay at home, and they'd go back to nursing homes. We'd slide back to nursing homes, which we can't afford. So the good news, I think, is that we have seen this coming. We have studied this. 15 years ago, I did a study on this. We know what the challenges are to supporting the direct care workforce. We know what the solutions are. We just don't have the political and social will to make it happen. So I hope in the next few minutes I have some time to talk about what some of the solutions are.
We can't come back. Let's stay on the direct care workforce and family caregivers for a moment and have you all talk about them. And let's put it in the context of those interdisciplinary teams that we need for all of us, but especially as we age. Tom, I know in the VA, there's some good work going on around creating those teams, as you mentioned. Talk about the direct care workers and family members as part of those teams and what you're doing.
So certainly a huge emphasis that VA has been moving in for a couple of decades is shifting care to the home. And you're absolutely right. In order to maintain individuals at home, very often they need a direct care workforce to really support that. And we also need to support the family caregivers for those who have a family caregiver. There are those who do not. So we have to think about both of that. And we're in the midst of very exciting times in the VA to really examine this. We'll probably hear more about this over the next few days as Veterans Day is in the news a bit. And we partner. We partner with Administration for Community Living. We do some things called like veteran-directed home and community-based services, where the individual has a budget to really help with this direct care workforce. Who do I choose to do that? So they have a budget to work with. It's a person, money follows the person kind of concept. So those are some things that we're working on. There'll be a paper that comes out this week with one of our partners between the Administration of Community Living and AARP on a piece of really around this person-centered care and how do we expand this and support family caregivers in that role.
The VA is doing a marvelous job. The first thing I ask when somebody calls me up and says, "What can I do with my dad?" is he a veteran? Because that's the one system that's really trying to make this work. But we're at such an elementary level. The AARP is very proud of getting the CARE Act that passed in a whole bunch of states. And it's a good act, and I'm glad it's there. But it's really awful that you need to pass an act to get hospitals to notify the caregiver when they're discharging a person who can't take care of themselves. I mean, sue the bastards, damn it. Don't just write a statute in the legislature. I mean, why did we ever think that you should do that? Send a person home without telling the caregiver, without training the caregiver, without even identifying the caregiver. You know, ONC doesn't require the caregiver to even be identified in the hospital record. They don't require that there be a slot. I mean, the most elementary of stuff we've skipped over. We don't provide any honor for the family caregiver. We don't provide any respite. We often let them get terribly isolated and thoroughly overburdened. I mean, what are we thinking about? We need volunteers, we need villages movements, we need support for the family caregiver, but most of all, we need a political movement that says, hell no, we will not keep doing this. We need a way for caregivers to have a political voice. In the last election, we got about 25 proposals into state party platforms to get caregiver issues onto the party platforms. It's never been done. I mean, we really need to rev this up in the 2030s. I mean, the VA's already hit it, but in the 2030s, the whole country will hit that kind of explosion as all those kiddies we were so proud of in the 50s toddling off to school are now 85. You know, it's not 65 that hits us, it's 80 and 85 that hits us. And we need to get the systems in place now, and in order to do that, we need to change the power relationships. We need to have a voice for family caregivers. We need to have a couple of voices for paid caregivers. We can't, we need an act up for old people. The reason that AIDS did well was because people were willing to stand in the back of rooms like this and say, stop saying sentences with nouns and verbs and periods as if it's all going to be okay, and paint themselves in the corner and yell. We don't have that. We don't have a movement that is actually outraged. And we need to say crazy things so that these midline proposals that we all calmly present become reasonable. At the present time, the kinds of proposals I put forward are seen as thoroughly bizarre. I need someone farther out saying, no, actually, we aren't going to deal with this anymore. We're going to really raise our voices, so that reasonable proposals with good evidence and all those sorts of things become actually talked about. So anyway, I find it as you can see, very frustrating, and really need, let's get Maggie Kuhn back. We need a Grey Panthers movement raising hell at meetings like this.
Yes. I share your passion and your urgency, and given enough time, I'd get revved up and you'd have a hard time shutting me up. Just to sort of convey that urgency, in Michigan alone, we already have a shortage of workers, direct care workers. We anticipate that we're going to need 30,000 more direct care workers by 2020, and that is less than 3 years away. We think we have a problem now. And the problem is, too, we don't need just more direct care workers. Let's say we found 30,000 workers somewhere. We don't want just warm bodies filling these slots, do we? When I hire a direct care worker, I want somebody who's qualified, who knows what they're doing, who's trained, who has the technical skills, but also knows how to deliver them in a person-centered way, who can provide care with some kindness and respect for the person's values, who likes their job and plans to stick around for a while, and who has a good attitude. The turnover rate, we not only have a shortage, huge problem is the turnover rate. It's just churning the system up. It destroys continuity of care, and it's very, very expensive. We have to stabilize this workforce. How do we do that? Obviously, they have to be paid more. I mean, that's a given, right? They are paid so low. They need better wages, better benefits. That gets really tricky because a lot of the work that's done by direct care workers is paid for by Medicaid. So you have these reimbursement caps. And every home care agency across the country will tell you those rates are too low. They're not going to be able to raise wages enough to make a difference, let alone pay for training programs. So we need different financing. We need higher caps, different financing mechanisms for wages and training. And why is training important? It reduces the turnover rate because it increases job satisfaction, for starters. But the work we've been doing in Michigan, we've been able to actually provide empirical data. There's an association between comprehensive personal care assistant training and better patient outcomes, including very costly ER visits. Lower ER visits, lower falls. So it's not just about the direct care workers. It's about the economy. It's about the cost of health care. The behavioral group before us, it's about the cost, housing. It all affects all of these systems. So more solutions come up.
More. And Claire, I'm glad you brought up training, and I want to touch on that a little bit in both for direct care workers, family caregivers, but also let's go back to the clinicians and health professionals that are out there. What is your sense, and anyone can jump in here, on where we are in terms of the adequacy of our education and training programs for healthcare professionals and the entire healthcare workforce, and when it comes to older adults? Where do we need to go?
Yeah, it is incredible to me that CMS is the major payer for physicians' postgraduate training, for residency and fellowship, and does not require that those trainings teach you about taking care of old people. So they pay for the cardiologists to learn all kinds of things about interventional cardiology and not how to make a decision with a patient and family as to whether to do the procedure. And nothing about sort of the behavioral issues and the rehabilitation issues that could be worked into orthopedic training and into nephrology training and so on, but we don't require that. Isn't that incredible? Our elder care system does not, and disability system, does not require training in elder care and disability for doctors. It's sort of the most glaring of errors in the training systems.
So a few things in VA, we have opportunities for interdisciplinary team training. But as you've said, there's also no requirement in general for making house calls, home visits. And so that's a big gap. And as we think about, in 1900, average age of death was 49, but we're now dealing with a huge American success story. So fortunately, many of us are living longer, and what's the one thing we're all going to experience, right? It's death. And we're making some progress in that area, but before that, most of us are going to have a phase in which it's high cost, high utilization, some disabling conditions, multiple chronic diseases, and we're not preparing our workforce to deal with that. That's why I feel like really strongly it would be really helpful to have a home-based primary care program in every academic center in the country, so every discipline could have an opportunity for that interdisciplinary team training. There are multiple benefits. It really benefits, obviously, the citizens of that state and their care. It also then benefits the trainees. All trainees have that interdisciplinary experience. It benefits the healthcare system because they're seen as innovative, and they now have a model of care that you can build as a foundation. Other really important models of care that can help this population meet the care needs at lower costs, like hospital in the home, adult foster home, medical foster home concepts, a lot of things that can improve upon that. And then if we take a look at it, in general, it's going to also have a benefit to taxpayers because much of what we're demonstrating that will reduce total taxpayer costs. So it can be a benefit to everyone to get that training out there. And that home-based primary care team is really valuable in getting into the home, seeing things that you won't see in the clinic, and finding out what that home support system is like. Does the caregiver need some training? How do we help educate that? And then identifying what else do you need? What direct care workers do you need so we can really ramp that up? But that's a challenge because we face that in the VA. It's like, there's a cultural, wait a minute, this is getting really costly. Yeah, when we start really examining, we're putting in place a better sort of case mix tool to identify not only those who need it, but about how many hours of direct care workforce help they need. It's really bothering a lot of people because they're seeing, wow, this costs a lot. Well, yeah, but look at the alternative, and we're not facing up to the alternative and the need.
And I think that raises some good questions. Let me see if, Claire, when you add to that, also think about these changing models of care that we do have, different payment systems, different ways of valuing care. and the changing landscape in terms of the delivery of that care. And I'm wondering if you can expand on those thoughts and maybe take us into that area as well, Claire.
Sure. So to follow up on what you were saying, I work in a medical school. I teach in a medical school, so I can attest to the fact that geriatric curriculum is negligible. It's shocking. I don't understand it. It's like stunning. How can we not see what is needed here? From a policy standpoint, for a number of years there were awards, the GACA awards. I don't know if anybody's familiar with those, but federally funded geriatric academic career awards to encourage clinicians, academic clinicians, to go into geriatric medicine, and those were eliminated. They were just eliminated. So now there's a push to try to get those back. But in many cases we seem to be going backwards instead of moving forward. So different models of care, I think we have to, there's this false dichotomy between health care and long-term care. And between, we talked about the false dichotomy between behavioral health and physical care. We need this continuum of care with continuity of care across settings from hospitals to home, where there's a safe handoff. We need to include the direct care workers and the family care workers in the team. We talk about interdisciplinary teams and never talk about the direct care workers as if they don't exist. We need training for them. We need to wrap social services around them. You can have the best trained direct care worker in the world. It doesn't make a bit of difference if they can't get a job, or if they get a job but don't have gas money to get there. Most of these people are on the edge, socioeconomic edge. They need supportive services wrapped around. We have to look at models of care that are more inclusive and a social model that looks at the total picture.
Speaking of models of care, I've become quite drawn to the PACE model, Program of All-Inclusive Care of the Elderly. Unfortunately, it has been thwarted in many different directions and actually growing. But in PACE, everything except housing, housing is the one thing that is not directly covered, everything that affects this person is covered in the capitation. And the PACE program is at risk for food delivery, is at risk for activities, is at risk for falls, is at risk for medical care and drugs and everything else. From onset to the end of life, you are in a program that makes sense, that has figured it out. It's almost as good as the VA programs, but it has one advantage that the VA doesn't have, which is that it is geographic. So they're responsible for a geographic area. What an idea! We have this nifty idea that it's okay for Hospital A to run a home-based primary care program, and for the VA to run one, and for Honor to run one, and for somebody else to run one, and they're all running all over town, wasting windshield time. Every other country organizes home care geographically. We have completely turned our back on the possibility of enormous savings by organizing home-based care geographically. DC has 60 home care agencies. Any one little apartment building out there could have 6 Medicaid patients with 6 different entities, each of which has a 3.5-hour minimum, even if the person only needed 45 minutes. We spent half of our Medicaid home care dollar on maintaining the illusion of competition. Competition didn't set the rates at all. Competition is not even available on quality issues. So why don't we organize something somewhat geographically? But we can't even talk that way because we're so into competition. But competition isn't actually yielding what we're looking to do. So let's think about some other possibilities. So PACE has the enormous advantage of radical continuity, thorough comprehensiveness, and a geographic population. Why don't we let it grow? Why don't we get out of its way and let PACE see if in at least a dozen communities around the country it could really be good. The VA can even use it. The VA has an agreement to use PACE. So we have a model that works, but we've 12 years, almost 20 years in, it serves 40,000 people nationwide. There are 40,000 people who need PACE between here and Baltimore. So let's get out of its way and let it grow and see what we can do with it.
And these models can provide a great training opportunity and way for infusing the competence and skills that are needed for the workforce caring for this population. I'm going to close in a few minutes before taking questions and getting your any ideas you have for specific policy options and recommendations that you think are really critical right now. And if you have any specific policy movement that you think we should be aware of, we're going to ask that. But I do want to pose one quick question that maybe one or two of you can tackle, because we heard from Project Echo just a moment ago. So I do want to just touch on, is there a role that you see for technology in assisting the workforce that's needed for the aging population? Any bright spots that you're aware of or comment you'd have around technology and innovation in that space?
Yeah, so, I talked about different teams we have, whether they're clinic-based or home-based, where we really want to provide better care in the homes of individuals. And the windshield time is a really expensive element of this. If we have a direct care workforce, they can be our eyes and ears. They don't need to be trained to be diagnosticians. They need to be trained to recognize something's different. And they can let us know. And with technology in the home, a simple screen that we can say, and this is what this person's looking like today, or why don't you talk to this person and ask the questions you need, whatever that is. But to carry technology into the home, we think is hugely valuable. Independence at Home, it's completed its third year of a Medicare demonstration, and hopefully when that becomes a routine Medicare benefit, that will allow the economics for home-based primary care to exist in every academic facility in the country and spring up. But integrating technology was built into that intentionally. But I just want to say one piece of good news. So the VA has taken a step to ask or to put in for authorization, and it's now through the Federal Register, and we're just responding to comments now for VA to have the authority to provide anywhere to anywhere, right? Care anywhere to anywhere. So that means in our clinic in Baltimore, if we have somebody in Pennsylvania, we can cross that state line with technology that right now outside the VA cannot do. So we're anticipating we'll be able to move forward with that fairly soon. So to be able to have providers cross state lines with the direct care workforce who's in the home, and right now we can do that clinic to clinic as Echo does, but not across state lines into someone's home. This is a huge move for us, and hopefully then when VA gets that established, it will help move the rest of the country into policy in that direction.
That's great. So let's jump to other important policy options and either specific federal legislation, regulatory action that you see is needed, or even state and local, which we really haven't had a chance to dive into. What's top of mind for you, Claire?
Well, several policies changes come to mind to support the family caregiver. If we just had paid family leave for elder care, and other workforce policies that are family friendly, so that they can get some relief without jeopardizing their own wages and employment. For the direct care workers, a policy change that I think is really important is right now you can get nursing home CNA training paid for through Medicaid, pre-employment training paid through Medicaid, but you cannot do that for home care. For the personal care workers, you cannot pay for pre-employment training through Medicaid. So why the difference? Let's recognize home care. We have this huge movement in the country to rebalancing, to bring people out of nursing homes into home care. How are we going to do that if we don't have a trained workforce in home care? So, there are a number of policy changes that could take place.
Thank you. Joanne, what about you?
Yeah, we've got to pass the Chronic Act. It doesn't do a whole lot, but it does some really good things and doesn't do anything bad. Clearly encourages use of technology. The Caregiver Corps Acts that a couple of people have put forward might well be worthwhile. There are 1,000 regulations in the way of good care. The one that I would focus on at the moment is that the Medicare-only person trying to get into PACE is the only person in America who does not get the benefit of Part D. And the payment goes from $35 or so a month for your Part D coverage to as much as $1,000 a month because you do not get the benefit of the catastrophic coverage that the government provides. It's a bizarre interpretation of Part D, but it's one of the kinds of things that this administration ought to be all over fixing, because it's just crazy that this person can't get the benefit of Part D. So the other thing that I would point to is kind of keeping from doing the bad things that are being put on the policy table. We really do have to resist things like blind Medicaid block grants and reducing carte blanche the nursing home regulations. There may be a number of regulations that need to go, but not just wipe a whole lot of them out. They got there because there were real problems. And on the technology issue, I would just love to see lots and lots of granny cams. We are so scared of the home care workforce doing bad things to people that you can't detect. And we have a technology now that could solve that. Just stick a granny cam in and you would know whether mom was being abused or being neglected. Why are we not putting that onto our smartphones so that we can check it out? And then that fear would go way down. So I think there's lots and lots of things that are possible. The thing that's missing, as you were saying earlier, is the will.
Thank you, Joanne. Tom, round us out.
Well, of course, I'd like to see independence at home become established as a Medicare benefit, but I'm also thinking about some partnerships, VA, in order for VA to do what it needs to do, and thank all of you, because 28% of all Americans over the age of 65 are veterans, so you're all taking care of veterans, and we appreciate that. Partnerships with the state. There are some barriers with finances that interfere with that, and so you think about a challenge of homemaker home health aid. You have to have a skilled nursing need. Well, what if you don't? There are a lot of people out there who really need that direct care workforce. They do not have an ongoing skilled need. You have to work out the operations of that to kind of really define who does need that. But working with the state and the VA together, this is a population that's hugely at risk to end up on in a big expense for the state through Medicaid. Can we come up with some partnerships and waiver programs so that we'd work routinely together to help support this person to stay in their home? Everybody wins. The person gets to stay at a much lower cost for the state and a lower cost for the VA by partnering.
Thank you. Let's take a few questions from the audience now. And if we've got a microphone, I see one in the back here, and why don't we start there?
Hi, my name's Marissa. In May, I'll be graduating from Mason as an adult geriatric nurse practitioner with a combined doctorate. And I'm a student who has a lot of loans, and I know that there's no incentive for me to work with geriatric patients, even though that's all I really want to do. So I'm wondering what opportunities you see to incentivize practitioners, and I think nurse practitioners can fill a large gap in this world for geriatric patients if more people were incentivized to do so. Programs that are offered by HRSA and Nurse Corps target underserved communities. The geriatric community is an underserved community, but it's not considered part of the community that I can serve and help get my loans paid for. So I really think incentives are a big part of this and the way to go. Physicians are incentivized to do primary care, but not geriatrics. It's crazy because this is where the world is going. So I'm wondering what your ideas are on how we can incentivize more practitioners to go into this field.
And I would say, I know the Elder Care Workforce Alliance, this is one of the areas that they focus on, is trying to advocate for programs like loan forgiveness, getting out to underserved regions. But any ideas from you, the panel, on how to...
I'll back that.
I'll go back to some of those things like, declaring this as an underserved population and then really putting some incentives into that, because it's hugely needed. But it's also, I got that question from Mark Miller in 2009 at MedPAC. He goes, I understand you have I'm starting to get interest in this home-based primary care concept of putting a bill into Medicare, but don't you have I understand you have a huge healthcare workforce shortage. I said, absolutely. I'm so glad you brought that up. What we need is an infrastructure with the economic sustainability to support people who make that choice so they can have a viable income going into this care model. So there's a number of things have to happen, probably some policy changes, the infrastructure in our care settings that would support what you want to do.
Another question? I see a mic. Let's go over here, front row.
Hi, Sharon Morgan with the American Nurses Association. I'm an RN, adult nurse practitioner, and I've worked in the space of hospice and palliative care. My home state is New Jersey. At one point, we ruled the nation on how much care was provided to patients at end of life. and did not change the outcome in the last 2 years. Part of this discussion is the discussion we have with patients and caregivers about when to say when. So I was wondering if you could take a few minutes and perhaps give us some illuminations on when we should start having conversations, how to have the conversations that talk about when to really maximize care versus quality of life.
Joanne, why don't you take that one, and then a few more questions after.
Yeah, I mean, the conversation needs to be going on as soon as you're either old or sick. I mean, it shouldn't just wait till kind of an end. And we really need to focus upon the comprehensive care plan. And the VA has a pretty good one going, at least for their inpatient nursing home and their home-based primary care. But the thing most missing in most of medicine is an adequate care plan. You know, the nephrologist thinks it's a care plan to tell you about your kidneys and the cardiologist about your heart, but we don't put in place a care plan that's comprehensive. And then we don't, if we ever do, we don't keep it up. So we need a care plan, and then an advanced care plan just becomes a natural part of that. You know, how do you want the advanced stages of this illness to be handled? You know, who in your family, who's going to be able to be helpful? Do you have helpful neighbors? What's your church like? What's your community like? We need to know a lot more about what kind of supportive services you can have. It's not mostly about turning off a machine or not doing a CPR. It's mostly about how you're going to live with serious disability. And we need plans for that. I have yet to find a place that is actually evaluating their care planning. It's the mark of an immature endeavor. We don't evaluate how well we're doing in care planning at all. So the one measure that would be important is whether your care plan reflects your preferences and your priorities and your real situation. And we aren't measuring that.
And so in VA, I just want to say that we are rolling out right now goals of care conversations throughout our enterprise, throughout our system, so that veterans, we train our staff. We all think we know how to ask these questions. We don't do very well at it. But so we're training our staff to have these conversations and to document that in the medical record. And some of that transports immediately into an order sheet so that there are things that can go on. And then it's also covered across. So in the VA, it's electronic health record across the country. But the goals of care conversations are really a critical part of that, building it into the care plan. One other thing, and as we do that, there's VA, but outside the VA, right, Bud Hammons, and some of the work that's been done on these, establishing your goals of care and your preferences and getting that down, and they've shown that they can change the culture of an entire community that way. And with Coalition to Transform Advanced Care, they're really trying to open that up and make that more available and widespread.
Yeah, and I do want to say that I think that conversation is now happening. How to start that conversation, and thanks in large part to Atul Gawande's book, Being Mortal. And there are now some really great resources out there, including toolkits on how to get that conversation started. And it shouldn't wait until end of life. These are conversations we need to have throughout life, because anything can happen to any of us at any time, any age. So I've actually had those conversations with my kids. So I encourage people to start those conversations really early, but get the help of some of these resource guides. I think there's one called Start the Conversation.
Yeah.
So
very, very important topic. And it does tie into the workforce and the training that's needed to really address the needs of all of us as we age. We are out of time, and so I think we'll have to close down the conversation for now, but please join me in giving a round of applause to our panelists. Thank you all.
Well, thank you so much to every single one of our panelists and moderators. I want to thank all of you for sticking with us for a really engaging discussion. Thank you. Thank you to Elder Care Workforce Alliance, to Leading Age, to AAMC, and to Anthem, Ascension Health is Primary, and to KPMG for hosting. Please join us for, actually, if you have a few more seconds, grab the blue evaluation form, which is in the back of your packet, and if you wouldn't mind giving us a little bit of feedback, that would be fantastic. But join us on December 8th for the final installment of our Future of Healthcare Summit series for this year. And once again, on behalf of all of us here at the Alliance for Health Policy, thank you so much for being part of our community. Thank you.